esteemed speaker, Dr. Avinash, who will be speaking on an appropriate topic on this FFF platform, which is already shared by eminent educationists, researchers, and scientists till now, till 29th episode. And now we all know we are amidst the COVID pandemic. Now, today only we had debated is enough to open up the reopening of colleges from within next 2-3 days. And I consider that we are all lucky. We are also lucky to have Dr. Avinash Supe to address this issue when we are already in the cross minds as what to do when the students will land here by Monday or Tuesday. Now, we all know that COVID pandemic has caused a disruption in the education of the medical students, and certainly it will have an impact, kind of a seismic impact, like, who are in the various stages of medical education. And such interruptions in education certainly will have an effect on their competencies, the deficiency in the development of competencies within the graduates. And we all know that if we don't take it, then we may not be able to give a proper product, proper Indian medical graduate to the community, which is very much in need of a competent Indian medical graduate having all competencies, especially to treat face such disasters. That's why I said it is at the right time that this burning issue for all of us in all the medical colleges across the country, the right man, Dr. Avinash Supe, Dr. Bhatt will be introduced. I only will say he is the one leader who has laid down the foundation stone of competency-based undergraduate medical education in India. We are very much lucky. Sir Avinash, on behalf of our Honorable Chancellor, Madam Chancellor, and the University at large, I take this privilege of welcoming you to this FFF platform created by AVMC. Vishnu Bhatt.
Good afternoon, Dr. Avinash Supe and all the esteemed delegates gathered on behalf of Dean HPE and management. I welcome you to this meeting. I don't think he needs much introduction because he has occupied various positions and also he's continuing to work very hard to meet the needs of the medical graduates everywhere. He has been the director and dean at the KEM Hospital, Sayan, Mumbai. He's also now emeritus professor after retirement to the GS Surgery and Medical Education Unit. You must be knowing he is one of the BC Roy Award. There are very few BC Roy Award winners. And he has been awarded Best Teacher from the National Board of Examination, ANBA, and other organizations. He has been the founder, director of Faimer program at Mumbai, and I am sure that he would have trained hundreds of people on the Faimer program. And he has been the ex-secretary president of association associated with the gastroenterology and hepatology associations in India. He has published more than 200 and he has got more than 1 lakh citations, which is very, very rare to see. And he is a member of the Wildlife, Nature, Medical Photography, and honorary member of the Photographic Society of India. And I remember having donated blood thrice, but he has donated 111 times. So he has got a factory for blood donation. Probably he is donating almost every month. And it is very nice to have him here. And you must be knowing he is also in charge of the medical education in the National Medical Council, and he will give direction during the COVID times. I think now we are going off the COVID times, but anyhow, I think his advice will be taken in the right spirit. And he has written various books and chapters, and I am very happy to present you Professor Avinash Nivritti Supe. Thank you, Dr. Mahalakshmi.
Thank you very much, Bhatt sir, for that nice introduction and very humorous one also. Over to you, Dr. Avinash. And before we start talking, there is a small announcement for the participants. This program is being recorded because we want to use it for future academic purposes. Please keep yourselves muted so that the audio quality is good for everyone. And any questions, any comments, please put in the chat box. Thank you. Over to you, Dr. Avinash. Stage is yours.
Yeah, I have actually shared. Are you able to see that slides?
No, sir, it is showing your, yeah, now slide has come, but it is not full screen. Can we make it full screen, sir?
I did that. Are you able to see it now?
Yeah, yes, you're good to go, sir. Please go ahead.
Sure.
It is
Thank
nice.
you. Thank you, Dr. Kotu, Dr. Mahalakshmi, and Dr. Vishnu Bhatt. Thank you for that generous introduction. And I really am happy to be here in this frontier group. And I would like to really discuss today on clinical teaching during COVID times. It's a very interesting topic, which all of us have really seen today. Now, I have no conflict of interest to really declare. And I would like to thank some of my colleagues as well as clinical case student, my library, and also the Vinayak Missions Research Foundation for all this. Now, I'm sure all of us have seen COVID pandemic, sudden lockout in India in March 2020. Colleges and schools were closed. Hostels were evacuated. Students went home. All resources staff focused on corona management, especially in the medical colleges, and medical education got disrupted. And that was not priority in the month of March. And that's what, if you really see, this was a global event. Now, if you look at globally, medical education came to an halt. Technology was used innovatively and rapidly to maintain teaching and learning. Some successes in online teaching, but potential areas of uncertainty remained. And there was a use of emergent technology for education, such as artificial intelligence for adaptive learning and virtual reality. And therefore, I think we need to really think what is going to be the future of medical education in this particular era. So I would like to cover some of these topics over this particular session. Now, if you really look at the COVID era, there were empty classrooms, clinical cases for teaching were very less, faculty and students not used to online teaching. And I think though some sessions were going, some institutes were doing online teaching, overall they were not used to, but they learned all of them. And online resources, there was always issue about awareness and access. And of course, duty times. Many people were working in the COVID time, whether it was preclinical, also were involved into all these duties. And that was what really happened. And therefore, this was an opportunity. And that was the and which started with online classrooms. Digital contents came up. Learn to teach online. And that was a major challenge for many faculty. Many elderly people learned Zoom for the first time, and these words like Zoom, WebEx, Google Meet, Team Link have become now common even in housewives. Pool online resources and stakeholders' role, that was something which was always thought. People wanted to work on online clinical classes, and this was where it happened. So there was a need to introduce online clinical classes learning and planning the overall online learning, implementing it, evaluation, and keeping the flock together. This is what is the current need. Now, there are no university much guidelines about this. Can I do it? Hello? I don't know much about computers. Which online platform should we use? What special preparations are needed and how much cost is involved? These were the questions in the minds of faculty which really came. So now when you think about online teaching, it is of two types: asynchronous, that is not in the same time. Student can access as per their convenience. And this is where came the Google Classrooms, YouTube, WhatsApp, and college websites. Synchronous classrooms, like all together, interactivity, live recorded, G Suites, and Team Link. So you could have both these can be done. So asynchronous is recorded, synchronous is live. Now currently what we are doing is a live session, while you could have a recorded session as well. Now, next question is, what is need in online learning? The first thing we should really understand is what are the domains of learning we are doing: knowledge, skills, and affective. Now, knows and maybe knows how is easier in online learning. Shows how and does is a little tricky and needs a lot of thinking before you are putting that into learning. So online classes in pandemic, lectures were immediately picked up. Most of the people started taking online classes. They use PowerPoints, they use their own ways of doing it, and the lectures were immediately resumed. Most of the colleges completed courses. Whatever academic councils I was, whenever I saw the report, I saw they have completed most of the lectures, preclinical and paraclinical. Maybe some of the very heavy government colleges could not really do it because of too much of corona load. But there was always issue about attendance, quality of these lectures, and the next question is always is assessment of these kind of online classes. But let's come to the topic of the day: clinical skills teaching. It's a major challenge. The major challenge for medical educators at present time has been to replicate the experience of clinical counters. These encounters range from clinic to ward rounds to interactive patients. You know, whether you are going to do rounds or whether you are going to do interactive patients. Are you going to have sessions to train interpersonal and interprofessional communication and clinical skills? And these are the questions which is a major challenge. So let's begin with the first thing. What are clinical skills? You know, I remember in Puducherry itself, in Jipmer, in 1995, we had a 3 days workshops to develop clinical skills. What are those and how do we really go about it? So if you really look, it can be divided into intellectual skills, psychomotor skills, communication skills, and team skills. These are one of the 4 major skills which you can really look into a clinical skills component. Now, if you really go deeper into a clinical skill, it could be divided into different components: history taking, examination, interpreting signs and symptoms, differential diagnosis, plan for investigations, interpret investigations, diagnosis, treatment, and counseling. These are the 9 components of any clinical skills. If you add assessment, which becomes the 10th component, and this is what is normally thinking about conducting a clinical skills. Now, if you look at online feasibility of clinical skills, can we take history and others? Yes. What are you worried about? Examination and assessment. Can we really do it? Rest all can be done because there is a lot of cognitive component into that. It can be easily done as a components of clinical skills. But today, with online videos and interactive sessions, as well as various kinds of MCQs or SKI which are conducted today, the all other components can be conducted to some extent. I'm not saying it is as good as physical, but there is a lot of we can conduct it with the presence of online teaching. So when you think about clinical teaching online, the major issue is of direct observation. Of course, it can be done through videos. It can be done with a very high quality videos, effective assessment of students and residents, giving effective feedback through online, orienting a learner, priming the learner, and of course, you can of course do a small group management in various groups, teaching multiple levels of learners and teaching procedures. Of course, this requires a little learning management systems and various kinds of groups where even we are using WebEx. WebEx can be used to develop small groups and work in those. We have conducted so many workshops through this where all these could be really done. Now, let's see what was tried by teachers for clinical teaching. All clinical discussions have been modified into case-based learning sessions. You know, rather than having a clinical discussion, what was done, instead of a patient, cases were used and a case-based learning sessions were created. Student grouping have been reduced to 50%. That is, sometimes they were physical, sometimes they're online. And when you're doing an online, I'm sure there are different time slots are given to each group, and this is ensures sufficient social distancing if you're doing it physically. Faculty in PPE places, the HEPA filters and high volume evacuation units are specially equipped. All standard PPE donning, doffing procedures are taught to students via video demonstrations and were strictly followed. In fact, if you really see, there are so many courses which have come from WHO to the local courses which are teaching students through videos demonstrations and recording of clinical procedures stepwise. Some from the YouTube as well as some are be recorded on dummy patients are uploaded for students. And if you really see the digital world today, it is a full of all these issues which are there. OSCE using mannequins and simulated models instead of real patients. This was tried by clinical teachers. Online teaching to students and were asked to practice on family members, submit a video of the same as assignments. This was tried by some of the medical college, dental colleges. And radiographic interpretation is taught online by uploading different radiographs with feedback. And that's the way teachers tried it. Let's go on clinical teaching resource library. One of the things which came out very well was Meded portal virtual learning resources during COVID-19. This is a free, it is a peer reviewed and is free at least during the COVID period. And Meded portal as such, if you register, it is free only. You can really access most of the Meded portal virtual learning resources. American Medical Association educational hubs, many of the modules are free. Some require AMA membership, but others have a cost. If you look at AAMC, Association of American Medical Colleges, clinical teaching and learning experiences without patient contact, all are free and they are easily available. Any GM videos in clinical medicine are free. They are freely available only for duration of outbreak. There are many other also people came out with, lot of agencies came out with these videos. .com, emergency medical cases, Khan Academy, University of Michigan Family Medicines, distance learning curriculum. All these are free videos. There are hours and hours of videos. You can pick up the way you want to do it, and then you can really do that. Now let's see, how do you get clinical cases? I'll give you a few examples. Now many medical colleges have a clinical key, and clinical key has books on short cases, and they are so good books you can easily use a clinical medicine. Like you have a hepatology, a simple obstructive jaundice case, it is given here. You can really develop it, and you can have all these kind of cases, questions which are there. There are a lot of questions which are already there, and you can really, these are the beginners. On an online session, these become your patients. If you look at a resource like Clinical Key Student, Elsevier Online, it is for specifically for students. It has books, videos, and images. And you have to go through, browse those books and really see what kind of books it will have. 250 cases in clinical medicine. They will have videos. I'm not going to show these videos, but if you see the physical diagnosis book, or if you show these testing pain sensation, they are so well explained that the clinical teaching can happen with the help of these videos. If you don't want to have a patient contact, you could have all the sounds can be really put down. Most important is you can do assignments online, and students love all these assignments. And there could be a simple way. Do you want to study mode or an exam mode? There are so many questions available. You can really pick up those questions and you do it. You can test the students, give them feedback. So all this can be used as an maybe alternative to the patients, and you teach them the clinical medicines. And it's a very simple test. There's a case scenario and there are questions to be answered. You can have a feedback and you can go ahead with this. You can use YouTube videos if you don't have access to the Clinical Key Student. There are simple videos like cranial nerve examination. You have an OSCE guide. Now, during COVID time, lot of these videos got uploaded. And if you really look them carefully, I'm sure you will have so many clinical videos for teaching which will be available. You could have suspected COVID experiences. You can really download them. Most of them are free. Now, the next question is, this was all about cognitive domain. When you are really trying to talk, how do you demonstrate skills? How do we create opportunity for students to practice? How do we support faculty in these new endeavors? And what will students think about new ways of learning? Now, there are a lot of sessions which were created. Look at Jefferson University. We can easily do it. You have developed a session on surface anatomy, identify important structures and landmarks in abdomen. And you have advanced sessions, students are asked to review written materials. You could develop a video, you could do everything. Abdominal examination, people wearing gloves in a single, either you have thing patient, or if you don't have patients, then mannequins. If you don't have mannequins, then standardized patients. Or if you feel sometimes have used their colleagues also to do these examinations. Virtual standardized patient encounters, this has happened for communication skills, and this is where people have been trying to look at taking a history of a patient of upper quadrant pain. Now, something called as remotely coaching students. Now, this is something which you should really understand how it has happened in the West. Simple online platforms such as websites and blogs can provide basic information, but can also offer opportunities to host videos for demonstrating essential skills such as procedural clinical skills and communication. And if you really see, medical educators can remotely coach students with real-time mobile video tools and app. Now, if you see this paper came in 2017. It says at home pre-residency preparation for general surgery internship, a pilot study. A very interesting paper, but one of my friend's son got admission into Mayo Clinic surgery residency. Now, before he started his residency, he got a kit at his home, and there were suturing material and there were all pads where he had to take stitch. What he had to do was he had to take those stitches onto that thing. He had to do that video of that, and he had to send to his teacher. And then over a period of month or two, he was trained to take good sutures by giving a feedback and few sessions on these videos. And this was a pre-residency program. That means before only he joined as a resident, there were multiple sessions of these clinical skills or suturing skills happened. And by the time he went, he had already mastered, or he was much better in his technique of taking sutures. Now, these are existent for last 5 years. Maybe they are not used in our country, but it's time now that we use such programs, what we call as online teaching, remotely teaching students program. Now, you can also have virtual COVID-19 patient case. This was another thing which was really tried. You have a patient who really says something like, you go to now banks. Whenever you go to bank websites, you will get all those kind of ARIA and those kind of people. So these are the people who will, if you answer one question, they will give you another thing, that I have a dry cough, and you say I would like to do. And higher level of all these PMP techniques have already been now coming, and this can be used for your clinical teaching. The most important is follow-up discussion. You have to have a Google Doc or any other platform, maybe it's a WhatsApp or follow-up discussion. Like in our Indian Association of Surgical Gastroenterology, for last 5 years, have every Monday clinical sessions, and these are followed by a WhatsApp discussion where people share their papers, small points, their researches, where depending based on the case. So whatever discussion happened in the morning, it is followed in the afternoon by those points, reviews, people discussing all that, and the issues get resolved. So it is very important to follow up discussions with all these issues. The most important what we need to do now is training the trainers. Webinar series, in-depth discussion sessions with in-house faculty. All elective surgeries are rescheduled. Opportunities to impart skills are limited today. That is a major thing surgical residents are facing. And surgical and all surgical related branches are facing this point. They are not getting an opportunity to operate except for emergencies and semi-emergencies. Video presentation on operative procedures, and you can really see now, you can really start working on them. So here came Professor Richard Satava, who many years ago, I remember, talked about simulation as a revolution. And he talked about whole surgical education, and today the level of surgical education, which was of few videos, has now reached to such a level that haptics have come into picture. And the coming of haptics has completely changed the simulation in surgical education. Things like touch surgery, surgery squad, virtual surgery, patient education, laparoscopic inguinal hernia repairs, all these have now become a practice surgical procedures. Now look at this kind of a video. Now here you get haptics feedback. There are much better videos also on this. And you could do everything. You can palpate, you can put your hand, it gives you feedback. You can go on cutting and it tells you how much is the pressure you have to use. So you can really teach student now much better way than what it was done before. You can ask him to take sutures, dissect it, and he gets a feel. I understand this is not as good as your regular patient, but if somebody has nothing, then these are the things which can definitely make our students, if for example last 8 or 9 months he has not operated, then these are the programs which are now available in India very easily, can be used to develop a clinical skill. Now stimulus based teaching is very important. There has to be a brief running simulated video scenarios, debrief. They can be tried, the teacher can be remotely present or students can be there with a small group, and there could be a scene, then there could be learning objectives, short description, skill labs and modules. So this could be really developed over a period of time. Now look at this 3D surgery simulation. This is another way by which, when the patients are less, what they do, they create a 3D simulated kind of a patient. It's a model of 3D, which is 3D printed, something like liver like this. And these are given to the patient, they are perfused, and then the patients, students on one side operate, surgeon operates on the other side. So the patient is operated by a doctor or the surgeon, but the students operate a replica. Now this is something which is very commonly done in the West, but in our country also this has come very regularly. Now 3D printing is available in India. In fact, my own institution uses it for neurosurgery, liver, pancreas. So start using in complex cases, and this is the way you can really train your students. Then there is a new programs have come, like simulation of COVID-19 emergencies preparedness. Now there are facilitators and there are various kinds of programs through which you can learn through simulation all these skills. So there are different ways of really learning, and peer-to-peer skill-based simulation, and that is peer-to-peer. The next question is, how do we really train students into communication skills? Now, theater of oppressed is a very good example of creating students and train them into communication skills. They become agents of change. I'm sure many of you have attended the theater of oppressed, and you could have really create a drama, and the students can learn with presence, improvisation, empathy, communication, reflection for action. You can create a communication skills laboratory in your own institution. There are videos available like role play angry patient explaining results. You could have give a feedback, and these are something which you can really get very easily today on MMI videos, what they call it, multiple mini interviews. So what is the challenge of clinical skills? Assessment is a challenge. Just a minute. All assessments postponed. Online open book types are also happening in some places, and it is responsibility shared by students. That is what has happened, but many universities have taken different approaches. I think most of the postgraduate exams were conducted in many universities. Like in our own university, we conducted super specialty and specialty. However, undergraduate exams are being now conducted over the next few months. So formative assessments can be done at departmental or institutional level. Develop an online module. Summative is university, where it could be mixed or online. Most of the people are trying to reduce the physical component of the exam and add an online component into even practical exam like Viva, and that has worked very well. It has reduced the exhaustion of the students and it has helped students. So it could be in-house program or it could be commercial program. There are so many commercial programs available, but you could create in-house program if you are a big institution. And I'm sure you could have a sample test, you could have MCQs, you could have multiple extended matching type. Now, when you talk about SAQs and LAQs, you can really do that. Standardized patients, simulations with models is another way you can conduct an exam. And does, when you are doing like mini CX, DOPS, 360-degree evaluation, or portfolios and reflections, they can be used. Now, out of which mini CX and DOPS require a physical kind of contact, but that can be easily done by using a video and you could have a different kind of an clinical reasoning can be definitely done by multiple choice questions or clinical based. Oral examination viva OC can be done through videos. Case examinations have been limited. National board conducted only one case examination for post graduation. Of course, it's a compromised exam. It's not actual the way it was previously regularly conducted, but during this COVID time people have tried this. And of course, mini CX is something way which people can do. You have definitely a room by which you can really see the student, how he is behaving with the patient, interviewing, physical examination, professionalism, clinical judgment, and then over a discussion with the patient and the student, I'm sorry, you can really make understand how he has really fared well. And these are the kind of rooms which are easily available in many hospitals, don't require much of thing except for the video and recording, and somebody can really see it from outside. There are many other toolboxes like workplace based assessment which can be used for postgraduates, and if you really see, there is a plethora of seats. Some of them can be used for undergraduates also, and this can be the way you can conduct exams. And documentation of work, direct observation, and you can really do it for assessing your students. Now, of course, there is a paperless assignment also being used. There are Google Forms people have been using. There were initial difficulties. People felt students don't pay that much of attention. Teachers found it difficult to really use. But you can use all these over a period of time for Google Forms, as well as Survey Monkeys. There are many other programs like Kahoot and commercial programs, learning management systems. All they can be really used for developing an assessment. So what are the challenges? NMC, initially MCI said that online modules are not really useful and they should not be used, but then NMC came and it changed its stance, and now online module, we published our booklet last week, and it is definitely possible to use this during the COVID times, and it bringing uniform online teaching and learning technology platforms for all medical colleges across country. The need for amendments in the pattern of conduct of examination, which may be short term or long term depending upon the prevail of a pandemic, and guidelines for relocating students back to college and starting colleges have come now. From 1st December, I think the medical colleges are opening and the first batch is coming from 1st February. I think we will have to really change the way we are really teaching and assessing students for at least next year till the time everything gets regularized. Training and faculty development workshops for medical teachers in regard to newer teaching learning technology, especially there are a lot of new wave, new technology. Everybody is buying different softwares. In fact, somebody uses new learning management systems. There is always a question between free or open access for e-resource material. In India, we always find e-resource material is costly. But I personally feel there are two ways to look at it. One, there is a lot of open access material available today. Most of the material during the COVID time is free to use. There is a good amount of sharing against the global community. And if your library can afford, then you should buy all these material and take the rights of that. And if your library is able to get online material, there is nothing like that. Understanding and adaptation to the newer technology for education, such as artificial intelligence, is very important, and it is coming in a big way. Now, let me end last few slides. I'm going to show you about what is coming in the world, and we should really look at over the next few years. The Horizon 2020 Teaching and Learning Report said that potential to transform future provision of higher education by adaptive learning and extended reality. Now, what is adaptive learning? Adaptive learning is a personalized approach to enable all students. Now, this is making students more competent than classroom teaching, and to access a wide range of learning resources and provide information to educators about how students are learning from their experience. So AI and learning analytics, learning analytics is most important. And from learning anatomy to complex clinical diagnostic management challenges are learned by adaptive learning. It's a self-regulated learning with a good feedback and monitoring from the teacher. And learning analytics collects information about the process and outcomes of learning that are essential to learn. And personalized learning that is tailored to the individual needs and there is also opportunity to reduce the time for development. I'll give you an example. When somebody is learning a laparoscopy, of course I'll give surgical examples because these are my specialty. Now if somebody is learning a laparoscopy, you can really do a video motion analysis, and you can see how his instruments are moving, what is his path of a instrument, what is his length and speed of instrument, and you look at the performance rating skills. This is our cadaveric lab and our lab where we used to train our students. And after that, you can get a graph like that, how much he has used his left hand, how much he has used his right hand. Now, if you analyze all this, then you can know that his left hand is weak, and then you give him exercises to work on his left hand. Oh, that is called as learning analytics. And then if you give him a feedback, this was a very nice paper which got published in Meda, it published that those who really try to do this change management, they learn much faster compared to if there is no change management. Learning analytics has a great role in, and so if you come to the CBME and programmatic assessment, formative and summative assessments for core knowledge have started to use variety of these online tools. And if you use all these AI, then you can really improve the competency through this kind of an assessment. So the next thing is augmented reality. Now, this is something which is coming in a big way. Extended reality blends physical and virtual elements, and it provides a totally virtual immersive experience with virtual reality. This is also fairly new in the medicine.
Placement.
Now look at this.
The closest to the pink zone. The rectum is closest to the red zone. So our green zone in the midline is the one with the greatest safety zone with both the ureter and rectum at safe distances.
Well done. In what direction would you place the suture? Speak the color of the correct arrow.
When we're placing sutures, our area of maximal control is the entry point. So we're going to put our entry point from lateral to medial, as that's going to be closest to the ureter. So I'm going to choose the arrow from lateral to medial, or the red.
If you were to kink the ureter with one of the three sutures, which one is the most likely culprit?
The distal suture is the one very close to the
So
ureter.
if you really
That would be
see,
the one to transiently obstruct the
if you
ureter.
really see in this, there is a video, you are working in augmented reality, there are questions asked, you are going to demonstrate it, and this is a wonderful preparation of skills achievement by the residents, and this can be done without really harming any patients. So augmented reality in surgery has been performance of the newly devised augmented reality system is comparable to traditional techniques. We really don't know about retinue. This was recently a surgical review was really published on this sometime, and we are still exploring, and this is something which I thought I must share with you because this is something coming in a surgery over the next few years. So what is future? I think future is going to be somewhere in the middle ground. Post-pandemic is likely to be in the middle ground between the two extreme ends of the spectrum. One hand, there is a complete traditional teaching with patients. On the other hand, this is a new world of augmented reality and adaptive learning. And there is a lot of online technologies in between. So use of technology will increase, and this will also include an accelerated application of many of the newer types of emergent technology. It's embedded with the face-to-face teaching. So we have to have face-to-face teaching and technology-based education. This is going to have a hybrid kind of a system and in the next future. So integrated approach is going to be the future scenario. So this is going to be a transformative change. Use of technology. The second is anytime, anywhere, what we call as a self-directed learning. So that people are using that technology offers a new opportunity for a specific group of students, such as increasing access. They can practice at home, they can practice somewhere else, and that's the way it is going to happen. Now, today you find some of the students are attending the 8th and 9th schools from abroad. That is what is happening today. Current increased spirit of national global collaboration of medical educators to freely create, share, and curate learning content should continue. And with the global solution to digital divide between high and low income countries, I'm sure what we have really seen in last few months is a digital kind of revolution. Maybe it was easily available to us, but this trend is not going to stop. We will continue to have this access, and we will create more access for this. And transformative change in the use of technology in medical education is on rise, on horizon, and we are going to see it over next few months or years. So what is the way forward? So our clinical teaching is feasible with various resources and emergent technologies, even in a pandemic situation. It may not be absolutely what is in your mind as face-to-face teaching. There could be some limitations. You may have to change the way you are going to teach. You may have to change what are the areas which you are going to teach. You may have to use innovative methods, but it is feasible. It will come close to the what you were probably used to achieve. Maybe you are giving little more liberty to students to walk on their own pace. Teachers and students need to adopt and get familiar with technology, need to develop our resources, and benefits of pandemic on medical education need to be enhanced in post-COVID era, and we must take this and pandemic as a good opportunity to revolutionize our medical education in next few years. Thank you so much.
Thank you, Dr. Supe, for that wonderful lecture. You took us from what is feasible to what is in the horizon. That was very nice of you. And we would like to go on record and see students, and we're using it. And one more resource which our teachers found extremely useful. If not for students enjoyed taking this lots of Coursera and edX courses because we subscribed, our institution subscribed for it. But it also helped the teachers to develop new competencies and ways in which you can present the online material. So that is as a postscript to your talk. And before we do, sir, can you stop sharing your screen? I am seen in your screen now.
I have stopped it. Let's see. I hope I'm able to see now.
Yes, sir. Yes, sir. No problem.
Okay.
So there are quite a few questions in the chat box, as well as questions which have come to me before itself. Can I take the questions, sir? If you are okay?
Yeah, sure. Sure.
Yeah.
I hope I have finished
Sir,
in time, so you have enough time for
yeah,
questions.
you finished time, sir. The first question which has come in the chat box is from Dr. Manjunatha Nagaraja. So he's asking, instead of each one of the institutions trying to develop their own strategies and resources to develop and train students using clinical skills using online resources, which might be very difficult for some of the institutions, why can't universities come together, or some centers of excellence can be done? Like Puducherry, I think we have a nice opportunity because we are 8 medical colleges in one small area. So that is what he is saying. Can you give your opinion on this, sir, please?
I
That's
think
what he
because of the
says.
pandemic, if all the medical colleges close by come together, I would be very happy. I think that's an opportunity everybody has to grab. And pooling of resources, especially, and sharing them. There are little copyright issues. Many of these companies will also see how many people are using it. But if you use a pooled resource, I'm sure it is cost effective, and students also can be benefited because of that. Some of the, like say, journal sharings has been tried by our university, but all these online resources and the subscriptions, if the universities take it and give it to all the universities through password and all, I think it is a very good idea, and that is the way probably forward which will happen. Remote. What is important is remotely access to whatever your resources. Most of the libraries across the world will have the remote access. In fact, my own hospital also, KEM, I started the remote access. So I can access my library from my home. And if you can really develop that kind of an thing, I'm sure that will be of a great importance. So your point is very well taken. We should uh, take away all the differences, come together, pool our resources, and benefit our students and faculty. I agree with you.
Thank you, sir. And there is one question by Dr. Revati Shri, and one more. The same question is reflected by Dr. Tanushree Mondal from Kolkata. They both are asking, how can faculty develop clinical skills training And the postscript for this question is, like CISP revised basic course, is the NMC planning anything to train faculty on medical education technology per se, not the pedagogy, but how to use technology for pedagogic purposes?
See, currently, I think the need before the pandemic, the skill labs were supposed to be developed. Many colleges develop skill labs. I'm sure you have one of the wonderful skill lab. I have taken workshop also in your labs. But over a period of time, I think there has to be individuals. Most of the teachers and colleges have to develop these courses. And if the need comes, I'm sure the academic cell and the universities should lead forward, and they should develop these clinical technology and technology in education courses for the faculty, especially. I mean, that has to happen.
Okay. Thank you, sir. Like, as you say, that we need to come together as a team and do it. And also, individuals have to take more responsibility so that we would like to utilize whatever facilities are available in that. Then, next question is from Dr. Pooja, who is a professor in Karamsand, Gujarat. She wants to know how to assess clinical competencies in the virtual teaching environment. Skills may be okay, we can use some models or simulation and do, but how do we go about assessing competencies in the virtual environment?
Fine. If it's the procedural skills, or if you're doing something like giving an injection or doing some small suturing procedures, it is easy to do it by looking at videos from different angles. It's not very difficult. But for assessing, we are able to really palpate a retroperitoneal tumor. It's little difficult, I must tell you. It's little difficult to palpate the deeper kind of lumps. Now, this is where the competency doesn't, I mean, that technical competency cannot be tested so easily. Of course, superficial can be easily tested, but that's what are, I feel, the limitations of the online teaching. But you can cover it in a cognitive way, in a clinical reasoning kind of a discussion. You can do it. But if the kind of very highly technical are very difficult to do on online teaching.
Yes, sir. And also, sir, many of the participants have put this question. Can you suggest some resources where we can find surgical skill related teaching online? Initially, you shared some in your lecture.
You can take this whole lecture. See, touch surgeries, all these are very there. I'm sure I shared many of these kind of resources. These are freely available. And as I said, Johnson & Johnson has these whole touch surgery events which can be really shared by, and they are easily available. So we can really do that. It's not something which is, but some of them require access. They are not free for everyone, but many of them will be access it through your institution if possible.
Okay. Just 1 second, sir. Let me browse through some other questions. Dr. Philip, because if I don't take up his question, he will get very upset. So this is Dr. Philip from MGMCRI. He wants to know between augmented reality and virtual reality, which is better to use to teach surgical skills or techniques?
Augmented is much better. Because that is, you can really plant your questions. You can plant, like for example, they were showing if while doing a hysterectomy or any kind of a surgery, how do you include ureter, how it is separate, all that can be planted into augmented reality. That's the advantage of augmented reality.
There is one very interesting question which I have found in the thing. So this is again from Kara, I don't know where it is, from Dr. Nandakumar, Associate Professor. He is asking what role can interprofessional education, especially technicians and nurses, can they share the responsibility of teaching residents and students during the COVID era, and how effective is this going to be?
Nurses definitely, but nurses were the people who were maximally loaded during this pandemic. Because nurses were on the forefront. So I don't think nurses have time to really teach, but they can be one of the people. Technicians and other interprofessional educations can take something like counselors, dietitians, other interprofessional technicians for something, teaching you the adjustments of things. they can all be taught, but there is a limited scope. It is not full scope, If you see the clinician's role is very different, others can be associate with them. But there are so many skills in that, something like, as I said, counselor, be a separate skill. Technicians, yes, up to some extent in the skill lab, up to some level, they can definitely teach you. But the clinical importance of this has to be taught by the clinical teacher. So they can add to your clinical teaching. They can teach you the basic things about that model, mannequin, or something like that. But the clinical relevance has to be added by a clinical teacher, and the higher level of cognitive skills can be added by the clinical teacher, especially the clinical absolutely needed, examples, because he has a wisdom, and a clinical teacher cannot be replaced in that aspect.
Thank you, sir. I think you brought out that point very nicely, with advancing technology and with so much of changes happening, teachers still retain their relevance. So
Yes.
before I close, I would like to ask Dr. Kotur if he has anything to share, and Dr. Vishnu Bhatt also. Sir, you are muted, sir. Dr. Kotur, you are muted.
Yeah, Professor Avinash, now we have left with only a couple of days. Now the Council has just what all the clinical touch that has been lost in over the past 8 months disseminated within the next 2 months to the time they have given. Such a Herculean task, what tips you like to give to the clinical teachers? Because what is not done for the 8 months, that has to be done in a concise way. Yeah.
Fine, sure. I think this is a very important question you asked. For example, let's take a batch which is going to go for examination, which was the first MBBS batch, which was to go examination somewhere in the month of September. Now, they were having regular classes till the month of March. After that, they had theory classes which were over. Now, what lacked in them was a practical class. So what they should do, 2 months if you're using it, minimize theory classes at this stage, concentrate more onto the practical classes, divide them into batches, use morning, evening for practicals, and complete their essential practical skills with social distancing. And that's the way they go for exam. That's what, and therefore they have kept their exam sometime after 2 months. So December and January is going to be for their revision practical classes, and in the month of February their exam is planned. That is what the new schedule of NMC they have put it down, and I think that's the right way to go. So for the first MBBS, when it comes to the clinical batches, they are going to have some losses, and the students will have share their also responsibility to cope up. So whatever there are essential skills which are common cases, we should try to teach them in a small groups, or with trying to work with the skill labs and the clinical. So give approach, especially for those batches which are senior batches, which are likely to go on exam. But fortunately, they have put all those exams after 3-4 months. So there's a lot of scope for practical revision. So I personally feel we should concentrate in groups, divide them into multiple groups, and concentrate onto the practical experiences which they have missed, rather than trying to spend time on theory. So this should be the approach of colleges we should really follow in next few months.
Sir, but are we taking for granted the theory aspect of it?
Are you changing the?
Are we taking granted for the theory part of it, saying that they will be knowing it?
No. Many colleges have.
You are muted, sir.
Sir, you are muted.
Supe, you are muted.
Okay, can you hear me now?
Yes, sir.
Yes, sir.
You only muted me, Mahalakshmi. That's okay.
Oh, no, sir, I was trying to mute
I think
Dr.
she was muted.
In that
Doesn't
habit,
matter.
no problem.
Doesn't matter. You are the chief, so you have all the rights. Now, see, many colleges have finished theory, so there is no need to repeat that. Maybe you can have few classes, you can have some questions, some examinations which can happen. There could be some areas where you can give them, but concentrate more onto the practical rather than theory. That is what my lesson, because that is what is going to help them to achieve whatever is there. And that is what the portion they have missed. The theory can be always worked up.
Whatever measures we take and try to do, certainly, there will be some deficiency as regards some of the competencies are concerned.
Absolutely. This is going to happen. We are, but globally, the whole world has accepted that we are going to have some deficiencies in this year, but in a 4.5 or 5.5 years, probably we will cover up these things.
Yeah. Thank you, sir. Dr. Bhatt, any comments, last words?
Yeah. It was a very interesting talk. I think we learned many things from the COVID, but I think ever increasing number of undergraduate and postgraduate students, probably we have no other go other than going to online classes, online skill teaching, because it may not be possible to do offline training for all aspects. Probably we have to do the online and enhance with the offline training, as you rightly put it, the hybrid model, probably that will come to existence. I think that's what on the whole, I think it was a very interesting talk, and I think we have to move forward in that direction.
Thank you, sir. Dr. Supe, there are a lot of messages in the chat box thanking you for an interesting and wonderful webinar. I think they reflect our sentiments, what we felt at the end of this talk. I'd like to thank you on behalf of the Scientific Forum of the Aarupadai Veedu Medical College, a constituent college of Vinayaka Mission University, for a wonderful talk and a very benefit of our participants. We would like to say that all of you who attended this session will get your e-certificates. Once you go to our link, you will get a link today evening. And once you go to the link and click the link, you can download your e-certificate. We'll also be uploading this talk in the YouTube, and you can actually see it in our YouTube channel, that is FFF webinar. So we can watch this session again. So on that note, we would like to close this webinar. I thank Dr. Supe for a very interesting session.
I pray that now all that cyclone and all is over, so you stay safe and stay healthy. Thank you so much.
Thank you, sir.
Thanks, Professor.
And for the information of the participants, we have a very interesting session next week. Next week, it is going to be a little bit more advancement of this talk only. We are going to talk about how to teach clinical decision-making skills. And it is going to be a panel discussion from the medical education team from St. John's, Dr. Sanjeev Lewin and his team of people, including Dr. Nachiket and Dr. Sunita and Dr. John. All of them are going to be there in that discussion, and they are going to talk about clinical decision-making skills, how we can teach that to the students as well as to residents. So that is the talk for next week. So as Dr. Supe said, stay safe, folks, and enjoy your time and be safe during the corona. So on that note, I'll close this webinar. Thank you very much. Bye-bye.
Yeah.